Okay. Hi, everyone. Thanks for joining us today. My name is Anastasia, and I'm part of the careers team at Mind the Bleep. We have some new members on the careers team, including myself, and we are going to be producing a series of webinars and articles talking more about different specialty trainings in the UK, as well as alternative career options. So to start off with, we have Mr. Nejc Steiner with us today. He is a consultant ENT surgeon from Slovenia. He moved here to do a fellowship in skull-based surgery, and today he's going to be talking to us about different subspecialties of ENT, common pathologies and surgeries seen, as well as the day in the life of an ENT SHO, registrar, and consultant. There'll be time in the end for questions, and I believe you'll also get a certificate of attendance afterwards, which you can add to your portfolio if you would like to. So over to you, Nate.
Thank you. Hello, everyone. So yeah, like Anastasia mentioned, today we're going to talk about how a day in ENT looks like. I'm coming from a small country in the heart of Europe. And for those who haven't visited, it's a really beautiful country. And if you have a chance ever in the future to spend a few days there, I'm sure you're going to like it. I guarantee it. So I finished my medical degree in Slovenia, in Ljubljana, on March of 2015. And then I did a residency in ENT in University Medical Center in Ljubljana from 2017 and until March 2022. Then I continued to work there as an ENT consultant, and I was head of ENT AMU department and head of ENT hospital's residency program. I also did a PhD, which I finished this year in February. I studied the effect of platelet-rich plasma in the treatment of tympanic membrane perforations. And as Anastasia mentioned, I'm an otologist and skull-based surgeon. And in order to learn about skull-based surgery, a fellowship is needed. And I decided to do one in Manchester. So I had to move to UK in September 2023 when I started. And now I'm slowly finishing this year, have approximately 1 month left. And then I've met and joined this group of great surgeons. One of them on my right side in the picture is Prof. Lloyd, and on the other side, Mr. Freeman. And I liked it here in Manchester so much that I decided to stay. So in September 2024, a few months, I'm starting as a consultant in Manchester University NHS Foundation Trust. So why have I decided to become an ENT? I was introduced to ENT in my 5th medical year. And at that time, I decided that I lost interest in facial, in plastic surgery and cardiothoracic surgery that I was interested before. And I was searching and waiting for something to inspire me. And when I went to ENT, an ENT clinic to be more precise, I saw cochlear implant fitting, or in different words, the first turn on of the when they turned on the cochlear implant for a child, which was 1 year old, and to see all those emotions of joy and happiness when he heard his mom's voice for the first time. Must say that it really inspired me, and I decided to become an otologist. And at this time, I've been involved in approximately 200 cochlear implants, and I've done approximately 100 myself. And still, every time I do it, it brings a big smile and a lot of happiness to me. And it's really inspiring that with medicine and a small device that we insert an electrode into a cochlea, that we can create hearing. And I love it. And that's why decided to become an ENT, more precisely otologist. And for those who haven't seen how it looks like when a cochlear implant is turned on, I suggest that you scan this QR code, and it's going to take you to a YouTube channel. There's a video of different people who experience the sound for the first time, and it's lovely, and I invite you to see for yourself. So if we continue and talk a little bit about which subspecialties are part of an ENT, as from the name suggests, ear, nose, and throat. If we start with nose, rhinologists see patients who have different pathologies. For example, on the top left picture, we see a deviated septum, and these patients have problems with breathing through the nose. And then with the surgery, we can improve that. We can straighten the septum and improve the breathing through the nose. On the picture on the top right, we see a schematic presentation, sagittal view of a patient with a conal atresia, where basically the nose is blocked from the throat. And on the bottom left picture, we see an endoscopic picture of a nasal polyp that obstructs the passages of the nose. And on the bottom right picture, we see a chronic maxillary rhinosinusitis. And in this kind of surgeries, a surgeon needs to open the passages to the sinuses in order to improve the clearance pathway and help the patient. Other pathologies could be nasal septal perforations, nasal fractures, tumors, cerebrospinal leak, rhinorrhea, etc. How do we approach the nose? So we can do the examination with something called anterior endoscopy, what we see on the top picture. It's basically where we use a speculum and just divide the nostrils and look into the nose. We cannot see much, but we can see if the patient has a septal deviation, or there's like hypertrophy of choanae, or if there's a foreign body sound, as we can see it like this. If we want to inspect the nose a little bit more in detail, then we use a nasal endoscope. We have two types of endoscopes. One are flexible and one are rigid. And for the nose, we mostly use rigid ones because a lot of times we have to go in and just push or move something in order to get a better view. So we covered nose. And if we talk about the throat, laryngologists or ENT specialists who subspecialize in laryngology see patients with different pathology, for example, like dysphagia, dysphonia, and patients that have other pathologies in throat also include quinsy abscesses or quinsies, tonsillitis, other tumors, or other pathology. Here in the bottom picture, we see a cleft palate. Mostly maxillofacial surgeons operate that, but we see a lot of patients like that. On the top right picture, we see a quinsy. On the top left picture, and the top right, we see a pathology on the vocal cords, and also on the bottom right picture. How do we approach the larynx? In a clinic, we can use a mirror to look behind the tongue and see the vocal cords. If we want to inspect it in more detail, then we can use an endoscope. In this case, it's a flexible one so that we can navigate it through the nose and look on the larynx from above. And on the right side, we have two photos of how we do the surgery. We insert a rigid laryngoscope through the mouth into the larynx, and then we can insert the instruments and operate on vocal cords. Because it's quite far away and such a small pathology, we need microscope, or in some cases we can also use exoscope. It's really rare. It's pretty rare, but it's basically a device that magnifies and presents a picture on a screen, and usually it's a 3D picture. If we continue to the ears, otologists see patients who has different pathologies. Again, can mention microtia, external canal atresia, ear infections, tympanic membrane perforations, hearing loss, vertigo, plexteratoma, tumors. On the top left picture, we see a child with microtia, and next to it is a tympanic member perforation, an endoscopic photo. On the bottom middle picture, we see a tumor of the ear, and on the bottom right, another tympanic member perforation, and that white part that you see, it's a cholesteatoma, ingrown skin. In ear, everything is really small in ear, and that's why we need a microscope, or more recently, surgeons started also to use endoscope. I mostly don't, just in a few cases, we can to look behind some structure that we cannot see with the microscope. But otherwise, I use microscope. And on the bottom left picture, you see endoscopic picture of the middle ear. And on the finger there, you see 3 little ossicles. And it can just show you how small they are. The smallest one is called stapes. And in a disease called otosclerosis, it's fixed. It cannot move. And that's why we have to insert a small prosthesis through it. And in this surgery, we have to make a 0.8 millimeter in diameter perforation in order to put in the prosthesis. So yeah, like I said, everything is really, really, really small. So just to look through everything that I just mentioned. So we have ear, nose, and throat, a lot of different pathologies, a lot of different surgeries, different approaches to the pathology. But that's not it. I'm sure you've heard about head and neck surgery. It's also part of the ENT, and basically it includes different pathology and different surgeries in the region from the neck to the head, and mostly head and neck surgeons deal with benign and malignant tumors of head and neck, deep neck infections, and sometimes when they remove big tumors, there's a big defect and it has to be covered with flaps, and they can be local, regional, and free flaps. It depends on the center, but in some centers, ENT surgeons do the flaps, in some centers, the plastic surgeons do them. Depends. And I've mentioned that in nose, we usually use endoscopes. In larynx, we can use direct laryngoscopy or flexible ones. In ears, microscopes. In head and neck surgery, just basically don't use any instruments. Some surgeons use, to improve the visualization, the magnifying loops, or in some cases, really rarely, the Da Vinci robot can be used in order to operate on the larynx. But like I mentioned, it's really rare. On the bottom right picture, you can see how we operate tonsils. We have a headlamp. And on the bottom left picture, you can see a nice example of how a surgeon of different subspecialists operate at the same time. In the top left corner behind, there are surgeons operating on the ear. In the bottom right, you can see that we're harvesting the fat from abdomen, and the closest to us is the head and neck surgeons taking the flap from the forearm radialis. So, ear, nose, and throat, head and neck surgery, and we also cover pediatric ENT. A lot of pathologies and cases are similar to the adult one, but they're present in different percentages, and some of them are also specific just to children. And then we have also from centers to centers. In some centers, we have only pediatric ENTs, or in other centers, we have surgeons that operate adults and children. So for example, otologists would operate ears on adults and children. So it depends, again, from center to center. And last but not least, part of the ENT is also skull-base surgery. And we divide skull base on the anterior skull base and on the lateral skull base. The main difference is that to the anterior skull base, we usually come, from the ENT point of view, we come through the nose, and from the lateral skull base, we come through the ear. And this can be quite difficult surgeries that take a lot of time. For example, for sure, most of you have heard about vestibular schwannoma. It's a benign tumor of the 8th cranial nerve. And if it needs to be operated, we mostly do it through an approach which is called translabyrinthine approach, which is basically through the whole ear and inner ear we expose the tumor and the internal auditory meatus. And from the anterior point, for anterior skull base, we go, as mentioned, through the nose. And in both cases, lateral and anterior, the ENT part is to create a pathway for our colleagues, neurosurgeons, then to operate on the tumor. And for example, the longest surgery that I've been involved in was started at 10 a.m. and we finished approximately at 1 a.m. It was a long one. Started with us, ENTs. We did the approach, for example, for 4 hours, for approximately 4 hours. And there was removal of a big tumor, which lasted for another 8. And in the end, also, there was some parts that we had to also do. For example, in some cases, the tumor is pressing so much on the facial nerve that the facial nerve, or basically the tumor is growing from the facial nerve and the facial nerve is lost. And that's when we need to do also the reconstruction. We harvested the nerve from the neck and then put it in between two ends of the damaged facial nerve. Okay, so now I talked about ENT and different pathologies, and as you've seen, it's a lot of different pathologies. It's a very diverse specialty. And now I'm going to talk a little bit about how a day in the life of an ENT looks like. I'm going to talk a little bit how the day of an SHO, registrar, and a consultant looks like. So in a hospital, day usually starts at 8 a.m. With the morning round. Depends from hospital to hospital, but SHO, registrar, and consultant usually go to the morning rounds. There they can see patients that were admitted from emergency department overnight. They can see patients who are inpatient after the surgery. They can see patients who are admitted for some diagnostic procedures, etc. And when they go on the morning round, they make a plan, a treatment plan, and ENT SHO usually get some tasks that he needs to chase. For example, they need to chase, for example, radiology or something else. And they also carry a bleep usually, and then they get referrals, which they discuss with the ENT registrar, who is responsible. It can be called like an on-call through the day ENT registrar, or in some centers they call them hot registrars, which is basically means that his responsibilities for the day are wards and everything, every referrals, and he's there for SHOs to consult him or her. And then the SHOs also cover a rapid access clinic, where patients who don't need to be seen immediately but needs to be seen in a couple of days time, then they come in and they're reviewed there. And depends from hospital to hospital and the amount of SHOs that are employed, then they also sometimes go to theaters. As a ENT registrar, as I mentioned, the one who's on call goes to the morning round, and when that finishes, they also usually carry a bleep, or they just reached on their phones if needed, and they either go to a clinic where they work with their consultant, different cases, as I mentioned before, and they can also go to theater. And usually they go there with the consultants, and they operate on cases together with the consultant, or sometimes when they're more experienced, they can also do a few cases on their own, more, for example, like tonsils, or adenodectomies and grommets, that kind of way. And in the beginning, on a specialty training, you always start with the more general ENT surgeries, which are tonsillectomies, adenodectomies, and as I mentioned, grommets. And then slowly we progress to more complicated, for example, like nasal septum deviations, hypertrophy of choane. So we basically do radiofrequency ablation, and then we progress. And a day in the life of an ENT consultant. So every ENT consultant has a different job plan, depending on the subspecialty. If the patients are inpatient or the day cases, the day starts with morning rounds. For example, in otology, most of the patients that we operate are day case, so I don't do morning rounds if we don't have patients hospitalized. And then every consultant has an individual job plan that consists of 10 professional activities per week. 1 PA is 4 hours, and it can be a clinic, theater, research if it's on the job plan, clinical supervision, and teaching. So if we continue and talk about out-of-hour on-calls, also depends from hospital to hospital, but mostly if the hospital covers ENT, SHO is on site. Depends from hospital to hospital. Again, it can be an ENT SHO, or it can be an SHO who covers different specialties at the same time. ENT registrar and consultants are on call from home. They have rotas. For example, now I'm on 1 and 6. So I have every 6th day I'm on call and every 6th weekend. Some hospitals, especially for ENT, for consultants, they do like week-long on-calls, or some do like daily, depends. And mostly also depends from trust to trust, but sometimes we cover multiple hospitals. So what are ENT emergencies, or basically what kind of pathology or patients we see on the on-calls? True ENT emergencies are epistaxis, post-tonsillectomy bleed, airway obstruction, peritonsillar abscess or quinsy, deep neck infections, foreign bodies, mastoiditis, and we can also say sudden sensorial hearing loss. As you see here, there are different pathologies, and some needs to be addressed immediately. Some patient needs to be operated on. Some patients can be treated with antibiotics, or some of them needs to be seen, like for example, for sudden sensorial hearing loss, it needs to be seen on the first available working day so that we can assess the hearing and then offer treatment with corticosteroids. But as a SHO, registrar, consultant, especially as an SHO and registrar, you'll see in the emergency setting more different patients, for example, with different infections in the ENT area or facial pulses in that kind of way. And a really good, how to say, an app or to use in this for SHOs is the ENT SHO app. You have a QR code here on the bottom right. Suggested it's really nice. It has the most important emergencies, how to treat patients with this kind of cases, in this kind of pathology, and when to escalate to your senior. So I think we covered a lot. And if we start to finish with the best and worst parts of the specialty, as in everything, it depends from person to person. What I like about ENT is the continuation of care, which means that we see patients from day one, we diagnose them, we operate them or treat them, and then we also see them on the follow-up. And I think it's something really nice to see. Develop a relationship with your patients, and I think it's really important that we see the patient from the beginning to the end. I like it. And then what else? A lot of what a lot of doctors, also ENT surgeons, say is that it's a very diverse specialty. So it means that if you like theater, like me, there's opportunity to operate a lot, to do very specialized surgeries. And if you prefer more clinical setting and more treatments in the clinic, that's also possible. You can create your practice in that kind of way. So, and because this is available, it also means that, for example, when you're younger, you can do something more. And then when you get older, you can change your practice in maybe to include more clinical setting in that kind of way. So that's a really good thing. From the bad things, like I said, it's different from person to person, and we can only hope that the bad things from the specialty are temporary, and that don't happen that often. And as I always say, being a doctor, it's not an easy thing. It's a lot of stress, a lot of hard working hours, and it helps if we choose something that we like. So I always suggest to everyone that you all think about the things that inspire you, speciality that inspire you, and then pursue it. And in that kind of way, it's going to be easier and you're going to like it more. If we just touch a little bit on the training program. So there was some part in the last years when there was a run-through program, but they stopped that. So if you want to become an ENT, you have to go through the core specialty training and then into higher specialty training. But I'm sure more things will be posted from Mind the Bleep. So just stay tuned, and I think that everything's going to be covered. And now, word back to you, Anastasia, and if there's any question from the audience.
Okay, great. Thank you so much, Nejc. That was really informative. So if there are any questions from anybody, feel free to put them in the chat. I did have something I wanted to ask. Is it possible to be a generalized ENT, just where you sort of do all parts of ENT, or does everybody subspecialize?
Yeah, so that is a possibility. Yeah, especially in, like I said, from different hospitals. It's different in different hospitals. So if it's a smaller hospital, usually more doctors would do a general ENT, like tonsils, septums, and that kind of way. And if it's a tertiary center, then doctors are more specialized into one subspecialty, or sometimes they cover two, depends on the needs.
Okay, and when you're on call, do you then cover all of ENT? Yeah.
So that's one thing. Yeah, even if I'm otologist and skull-based surgeon, on calls we cover everything. So from nose, and also depends from the center again if they covers children. So also sometimes we have to also cover children, pediatric ENT.
Okay, all right. And then also, are all the procedures done generally in theatre, or do you do some procedures in clinic or in local?
So yeah, the nice part of ENT is that a lot of things can be also done in the clinic. For example, from otology, we do transtympanic injections. In clinic, in the treatment room, we spray silicone spray into the ear, it numbs it up, and then we use a really thin needle just to insert it. We can insert grommets. We can do a laryngotomy, basically make a little cut in the eardrum and then aspirate the fluid behind the ear and immediately improve the hearing of patients, for example, after an ear infection. And also some things can be done from the nose, in rhinology, and also especially laryngology. A lot of things can be done in the clinic. For example, have flexible endoscopes with a working channel, so they can insert like instruments through it, and they can remove some polyps or something from the larynx, or they can use also laser in the clinic, remove polyps, and then patient goes home immediately after the procedure.
Interesting. All right, we have a question on the chat. Would you recommend any resources or journals that would help us understand more about the demands of the different subspecialties within ENT? Yeah.
So I would recommend two things. One is ENT UK webpage. Offers a lot of different like subspecialties, courses that are available, conferences that you can attend, and it's really detailed. So I would recommend that. It's called ENT UK. And the other one is from the RSM. They also have a otology division, or rhinology, laryngology, and it offers a lot of like different introductions to ENT, and also offer conferences, and they're mostly held in London. And it's a really good, nice thing, yeah.
Okay, another question. Is there much overlap between ENT and anesthetics and airway emergencies?
Of ENT, anesthetics, and in airway emergencies. Yeah, so it is, for example, we all know if there's an airway emergency, a true airway emergency needs to be addressed immediately. And ENT registrar and consultant are on call from home, which means that we need sometimes up to maximum 30 minutes to get into the hospital. And that it means that anesthetist needs to address the patient with airway obstruction, which means that usually when we arrive, the airway is secure.
Okay, so if it's like a tracheostomy or something.
Yeah, exactly. We always work together. So they secure the airway, for example, intubate the patient, and then we address the reason for airway obstruction. Sometimes if it's a tumor that's obstructing it, we need to proceed with the tracheostomy. Sometimes we can just wait, or sometimes we can give some corticosteroids, and that helps. Depends from case to case. But yeah, usually it's the anesthetist who secures their airway, helps the patient immediately, and then we address the problem later.
Okay. Another question. In a week, how much time do you spend in theatre and how many clinics do you do? Yeah. And then if you are a skull-based surgeon, do you do other generalized clinics or only your subspecialty?
Yeah, it's a really good question. So how many theatre clinics? So now that I'm on a skull-based fellowship, which basically is meant to be that the fellow operates as much as possible. I'm mostly in theatre, but registrar depends. Depends also on the trust and depends also on the hospital. But mostly there's like a day in theater and day in clinic, and then day doing something else in that kind of way. So it's difficult to answer. But for example, in the hospital that I work now, I think there are 3 to 4 registrars and a list every day. So there's always a registrar on the theater list. We try to maximize that as much as possible. And as a consultant, starting for September, and then it's like, for example, my plan would look like on Monday we'll do a clinic, Tuesday also clinic, Wednesday theater, and half a Thursday clinic, and then it a little bit changes in the week 1 and week 2. So I would say mostly 50% of that kind of way.
Okay.
So yeah, another question was if I, as skull-based surgeon, do any generalized clinics or only your subspecialty? So me, I'm as an otologist and lateral skull-based surgeon. Then I cover only otology patients and lateral skull-based patients. But this is again different from hospital to hospital. In our hospital, which is a tertiary center, we're very specialized, and we do only our subspecialty, except when we're on call.
Okay. But perhaps at a smaller hospital, like a district general hospital, the ENT might do clinics with all areas of ENT.
Yeah, there are. So this case is for me, but there are doctors who would do, for example, they would have voice clinic, and then they will have normal generalized ENT clinic, and like that. And then you have rhinologists who do just rhinology and anterior skull-based clinic. So it depends, and it's the nice thing is that you can choose how you create your practice.
Mm-hmm. Okay. Just wait to see if there are any more questions anyone wants to ask. Just wait a few minutes. No? Okay. Well, thanks so much for talking with us today, Nejc, and thanks everyone for joining. I hope you found it useful and beneficial. Oh, we have one message. Oh, just thank yous. Everyone's saying thank you.
Great. Okay.
Yeah. So
thank you everyone. Thank you, Anastasia, and Mind the Bleep. Continue doing the great work.
All right. Thanks very much. You can fill in the feedback form. It's posted in the chat, and then you also get a certificate of attendance as well, like I mentioned at the beginning.
Thank you.
Thanks.